So our next presentation is actually a co-presentation, and I'm very pleased that we have both a physician and a nurse practitioner, because so often the models of survivorship care actually include this dyad, this multidisciplinary approach to care. So we have Mark O'Rourke and Gina Franco, who will talk about their own successful work, both challenges and opportunities in Community Cancer Center in South Carolina.
Good morning. Thank you. I'd like to thank the organizers for our chance to be here, and all of you for coming this morning. My name is Mark O'Rourke, and I'm a medical oncologist and cancer specialist in Greenville, South Carolina. We aren't as big as the state of Texas, but Greenville is the home of the BMW automobile plant, and BMW now stands for Bubba Makes Wheels. So we have a hospital, Greenville Health System, and we see 31,000 cancer patients a year, 3,100 new cancer diagnoses a year, and it's a big and busy practice. I've been in oncology for 30 years and was in private practice up until 5 years ago when our practice became part of the hospital. And it was at that point that the hospital said, we want to have a survivorship program, and we want to use our resources, including our employed physicians, to run that survivorship program. So I was asked to be the part-time medical director for this, and the first thing we were able to do was hire a nurse practitioner, Gina Franco. And this morning we'll talk about what we've done in the last 5 years to develop our survivorship program. I want to emphasize that I think that there is a clear straight line from the Institute of Medicine report in 2006 to the Commission on Cancer in 2012, saying that to be accredited, a hospital must have distress screening and it must have survivorship care plan delivery. And that was what pushed the administration of our hospital to say, okay, we need to invest in a survivorship program. And that has been the lever to encourage our administration to let us build the program. We began with a model of destination clinic. We called our program the Center for Integrative Oncology and Survivorship. We knew we wanted to emphasize survivorship, and we wanted to emphasize integrative medicine as well, and we've done that. And we started off small as 2 offices and a hallway, and we began developing survivorship care plans and bringing people in to have their survivorship care plan visit. So rather than go to the 5 or 6 different offices around the Greenville County area, we had the patients come to our center at 900 West Ferris, and we would sit down with them in a 45-minute visit and go through their survivorship care plan, but also talk about lifestyle, health promotion, exercise, and the things that are important, and in particular, distress screening. And we found very often that our visits would go off into the distress screening direction and emphasize the psychosocial aspects of the cancer experience. And this was something that we wouldn't have discovered otherwise. So my partners, my colleagues, provide cancer care. Their patient comes over to see me in the survivorship clinic, and I'm surprised to see the opening up of all these personal issues, emotional issues, psychosocial challenges, and it's been our pleasure to work on those. So the hospital did have an oncology rehab program in place. So we, across the street, have a healthcare facility, a big gymnasium and exercise program where they have cardiac rehab and pulmonary rehab. We've had oncology rehab there for decades, and that has worked out nicely. The hospital pays for a nurse to organize a group of 12 survivors to come an hour, 3 days a week for 12 weeks for what we call our Moving On Oncology Rehab Program. It's been tremendously well received, and the patients love it, and it very much jumpstarts their effort. Many people are not ready for an exercise program at a gym, and we refer them to physical therapy in the hospital. And from the hospital's viewpoint, that's one of the positive things that we see, that is referrals back to the hospital. We have counseling provided by a social worker. So In addition to the nurse practitioner, the hospital funded a social worker position, but the social worker's job for 3,000 new diagnoses a year was to take care of all the distress screening, to organize that, and to respond to those needs, and then to do individual counseling in our center. We persuaded them to hire a dietitian, so we have a dietitian providing nutrition services, and at first we had the dietitian and social worker and nurse practitioner all in one big visit, but later on we separated that out. We've also had our genetics counseling program. We put that into the Center for Integrative Oncology and Survivorship. The same nurse practitioners who do the survivorship care plans, we sent them to Duke to learn about the Quit Smart smoking cessation program so we can offer smoking cessation services to patients. And this is a visit with a human being. So I can refer someone from my office for smoking cessation and tell them that they will see a nurse practitioner and they will go through a program where they taper their cigarette use, not stop instantaneously. And it's been pretty well received. The challenge is getting people there, but once we can get them there for that first visit, we've had a pretty high success rate. And finally, we've developed these lifetime cancer surveillance clinics where patients, after they've been followed for a number of years, can then go to that clinic and be followed by the nurse practitioner and don't need to follow up with the oncologist anymore. I want to mention the South Carolina Cancer Alliance, which is an alliance of people interested in cancer in South Carolina. We have a wonderful statewide organization that has a survivorship care subgroup, and we've had periodic meetings, including 2 annual evidence academies. And I can recommend this model for other states. We have about 17 hospitals that are Commission on Cancer accredited, and people from these hospitals get together for these evidence academies. We share information, share experience, and it's quite encouraging to the people out there. So our program is relatively big, but for other hospitals, it's one nurse or one social worker who's told you're the survivorship person and you need to develop a program. The other thing that's helped us is the cancer support community. It is a national advocacy organization, and it's a collection of small community support centers and where people come to share their experience with others. And it's been, for us, a helpful comprehensive support and education and healthy living programs. We were the first hospital affiliate of the cancer support community, and we have benefited from their helping us develop programs, but also from using their online capability and their free telephone access for financial counseling and personal counseling. To review our story then, we opened in 2012. Initially, we used this Journey Forward template for the survivorship care plans, and then we added programs, lymphedema management, the smoking cessation was the important one, and we switched ultimately to the ASCO template. And for a while, we had care plans for each different diagnosis, and we would have a nurse navigator develop these care plans, and then we would switch over the care plan. We would deliver the care plans individually, and we found that it was just too time-consuming. It was just overwhelming. And one of the real issues that Gene is going to develop is just how time-consuming and how difficult it is to develop these care plans. So in 2014, we changed to a generic, shorter care plan, and we used our visits more to address the psychosocial issues and the lifestyle issues and the exercise and nutrition aspect. And we also developed a way to use our tumor registry to generate the data for our survivorship care plans. In 2016, our hospital developed the EPIC software, and within EPIC there is a survivorship package, but it was not helpful for us. We just couldn't make that work. So we still generate our care plans from the tumor registry database, and we scan them into the chart. Looking to the future for us, we're adding, we do have an onco-fertility program. Our fertility people are standing by, and we're able to include patients and get them seen within 24 hours. We developed lung cancer screening, breast and cervical cancer screening. We've developed a one time visit AYA, Adolescent and Young Adult Clinic, and we're working on a high-risk clinic for the people that we identify in genetic counseling for them to have some guidance and follow-up going forward. Under development is the idea of a sexual health visit and also spiritual navigation. So we have a chaplain who has, I wouldn't call it non-denominational, but interdenominational resources. And people get together and talk about their cancer experience and the meaning of life. Our status report now is that we're a busy monthly operation. Our clinic creates referrals, and our cancellation rates are similar to primary care. I'm going to turn it over now to Gina, who's going to talk about the nitty-gritty details of how we grew our program from 2 people to 32 people and how we persuaded the hospital to fund all this in the last 5 years.